Okay, next we'll hear from Daniel Bennett, an associate professor of economics at the Center for Economic and Social Research at the University of Southern California, and he'll talk about depression and the demand for a novel health product.
Thank you. Thank you, everyone, for giving me a little bit of your time today. I'm actually going to describe two papers that are based on the same project, and I'm hoping that I can do this in the allotted time, and it'll bring in additional results that will be useful for discussion. And so and this is, I should say, joint with Manuela Angelucci, who is at University of Texas, and we have this agenda where we're trying to understand the linkage between depression and poverty. And so what we did was that we implemented a randomized trial in 3 taluks north of Bangalore, India, where we screened people for depression and offered a subset of them 8 months of free pharmacotherapy. And so pharmacotherapy means SSRIs such as Prozac, and is distinct and complementary to treatments like cognitive behavioral therapy that would involve a meeting with a counselor. And the evidence base about pharmacotherapy is limited, but it is interesting because, as Gautam was saying, there is a dearth of providers of mental health care in developing countries, and this is one way to economize on human capital because it requires less expert hours to do this than to do traditional therapy. And so we implemented this treatment in conjunction with a local research hospital, and I should say what we did was we kind of referred the patients to the hospital where they received care as was designated by the psychiatrists, and we cross-randomized this. In this paper, I'll focus on this aspect of it. We cross-randomized this with an intervention to offer livelihoods assistance to people. And so livelihoods assistance, if you're not familiar with this, is a kind of common intervention where it's not kind of like giving people jobs. It's more general than that, where you identify what are the things that someone needs to improve their socioeconomic circumstances, and you try to tailor benefits to them. So it's a little like social work, you might say. And so we assess impacts of these two interventions, both jointly and separately, on depression, socioeconomic outcomes, and several potential pathways that may link mental health to socioeconomic outcomes following a pre-specified analysis plan. So the psychiatric care intervention, as I said, most patients received SSRIs. It lasted for 8 months. You would typically meet with a psychiatrist once a month. And initially, there would be a longer meeting where you would talk about your situation, and the doctor would understand better how to treat. And then the follow-up visits focus on how to adjust dosages or change drugs or any side effects, that sort of thing. The livelihoods intervention involved 2 initial group meetings where people talked about how to earn income and how to deal with on-the-job challenges, and then personalized assistance to identify and pursue income-generating activities. I think I want to emphasize here that the livelihoods assistance intervention doesn't seem to do very much independently. It doesn't increase income or labor supply, but there is an interesting complementarity that we see where it magnifies the impact on mental health. And so I suspect, I'm conjecturing and we can't really know for sure, but I think that these 2 group meetings at the beginning may be important, and that the results are going to kind of say that pairing pharmacotherapy with a light touch intervention such as livelihoods could be important for magnifying the treatment effects of mental health care, as well as attenuating or providing protection from some negative or potentially negative effects that we see in the short term, so transient, kind of transitory effects that we see in the short term of the pharmacotherapy. And so first, we have impacts on depression. And so this is just showing you the distribution of PHQ-9 scores across the 4 intervention arms, and the one on the left is the arm that got both the livelihoods and the pharmacotherapy, and the gray on the right is the control group. And so you see that the arms that got either the PC, the pharmacotherapy, or the LA, the livelihoods, are a little bit to the left of the control, but not as much. And so that's the result I was just talking about. And then the other thing to note is that on the right panel is after the PC intervention had concluded. So this is up to 28 months after baseline. And so, and we see that there's persistent benefits in terms of mental health of this joint intervention. The other thing I'll say about the joint intervention is that if you're thinking about, from a policy perspective, how we could be treating people, this offering these things in conjunction is a standard way to implement this. So the NGO that we worked with, this is their model, is that they try to both provide economic assistance and mental health care. And this is suggesting that is, there's some sense in doing that. As I said, we don't really see effects on labor supply. So these are estimates for work time on the left, and then earnings on the right, and we're not getting significant benefits there, either in the immediate period during the intervention or in the rounds afterward. There's this effect of only receiving pharmacotherapy that is negative in the earlier periods, and we have some thoughts about what may be going on there, but you see that when you get both things, that goes away, and so that's what I mean about the protective effects that seem to be present. The biggest thing that we see coming out of this is an effect on child human capital investment. And so this is a result that we see mostly later on because enrollment is sticky and it's something that happens on an annual basis, and most of the earlier period was during the school year. But then when we look at the subsequent school year, we see increases in school enrollment, decreases in the probability of engaging in child labor. And these effects are particularly large for older children. And so that's the result on the right. And so you see here the biggest point estimate is for people who are in the arm that only received pharmacotherapy, but we can't statistically distinguish between the 3 interventions in terms of their effects on education. This relationship with education is something that we see elsewhere. So Gautam mentioned the Baranov paper in the AER is also finding effects on education, and I think in child development, this is another relationship that is known to exist, and so it's reassuring and also I think very interesting that we see it here. When we look at other socioeconomic outcomes, we don't see very strong patterns. No effects on hygiene or sanitation. Durable goods index is a measure of wealth, and so the main thing I think that we take away from this is these effects on education. We look at several potential pathways, and here I want to call attention mostly to this result about risk intolerance. So we see that people are becoming more risk intolerant, particularly in the later survey rounds. And this, I think, it helps us maybe understand somewhat the mechanisms that may be underlying results for education, or at least could potentially be important for why socioeconomic outcomes could change. Depression, one symptom of depression is anhedonia, which means like a flat affect, and economists would conceptualize that as a low marginal utility of consumption. And if someone has that symptom, they may have limited utility from taking actions that increase their consumption or from taking actions that avoid reductions in their consumption. And so you may think of education and investing in education as the former. And the risk intolerance really is a measure of the incentive to avoid negative shocks. Particularly the way we measured it, it's about, are you willing to wear a helmet when you ride a motorbike, or will you leave your child at home unattended? And those are things where if it's like protect prevention behaviors, right? And so if you are willing to avoid negative shocks, then that is also, that may, so economists may think of this as kind of like risk aversion, and I want to kind of say it's not necessarily that. It may not be about the curvature of utility, it may be about the slope, that I receive more disutility from negative shocks when I'm less depressed. And in fact, we measure negative shocks, and we see that households experience fewer of them in the treatment arm, consistent with this sort of interpretation. So there are some policy implications of this. First of all, there's not very much evidence about the role of pharmacotherapy in developing countries. There are no meta-analyses of pharmacotherapy. And as I said at the beginning, this may be an important tool in some contexts that may be complementary to other things such as training lay counselors. And absolutely, I agree with the idea that we need to find ways to provide mental health care and increase access and take-up of mental health care, and that this may be an important component. And then the other key takeaway is the role of the LA intervention, I think, is interesting. In that LA costs $9 per participant. It's quite inexpensive. And yet you see when you pair these together, you get much better results for reasons that are not completely clear, but should suggest further study. I think this is something we should understand better, to what extent pairing light touch interventions with deliberate mental health care is really important. So I want to now just spend the last few minutes talking about some new work that we have based on the same project, which is to which helps, I think, understand mechanisms underlying kind of the economic behaviors that may relate to depression. And so there is a literature in economics that studies the demand for health products. This is from Dupont and Miguel, Handbook of Economics of Field Experiments. These are all studies of the demand for health products such as bed nets, vitamins, water purification. And a common finding in this literature is that there is high elasticity of demand, and people are not willing to pay very much at all. And this confounds policymakers, because you'd like to charge people a price which would allow you to offer the product to a broader set of people, but if you charge them any little price, then the demand falls off dramatically. And so people have thought about different explanations for this, such as liquidity constraints, information, behavioral biases. And what we want to suggest is that depression and pervasive poor mental health may contribute as well to this phenomenon. And so that may seem sort of out of the blue if you haven't thought about it, I guess, but several of the symptoms of depression relate to the way that people assess the utility of a novel health product and may affect their incentive to take up. And so, for instance, anhedonia, as I was describing, may reduce the utility you receive from adopting a new technology. Pessimism about the returns to that technology may make you not want to take it up. And indecisiveness, which we can think of as like a fixed cost of taking action, may make it so that you can't kind of get up the will to take action about something that you're not as familiar with. And so we ask, does depression affect the demand for a novel health product? And if so, which pathways may be important? The product that we offered was hand sanitizer. And this is interesting because this is a setting with poor hand hygiene, pervasive diarrhea, and we need new ways to try to help people overcome, diarrheal disease. And so we offered depression treatment, as I've described. Along the way, we gave most people free hand sanitizer, because one of the mechanisms we're interested in is whether depression moderates your ability to learn about a new product. A little bit later, we measured the use of the product. And later after that, we measured the willingness to pay for hand sanitizer using the Becker de Groot-Marschalk incentive-compatible mechanism. And so what you see is there is this relationship. And so these are demand curves, or inverse demand curves for hand sanitizer. And the red is the people who received depression treatment, and the gray is the control. And you see this shifted out demand. This is statistically significant. The results are biggest on the right, which is where if policymakers were offering modest subsidies, that's what they would be doing. So this is a new relationship that we hadn't known about before. One interesting thing about this is that, this is a novel product. And so we ask kind of to what extent is novelty important? And so in the same context, we also, in a using similar methods, sold people biscuits, cookies. They're a common product that people know about and can buy locally. And here, you don't see the same relationship. You do see a little bit of a positive effect, but it's about 30% as large, and it's not statistically significant, and we can say it's significantly different from the impact on hand sanitizer. We go into the mechanisms a little bit to try to and use this to unpack the mechanisms. And one result that's striking is here what we have in column 4 is willingness to pay, and you see this positive effect on willingness to pay. But when you look at use in column 2, you don't see an impact of depression treatment on use, conditional on having received it for free. And this is weird. So we're going to give it to you for free, and you're going to not actually use it more, but then when we elicit your demand, there will be a response there. And that, I think, helps us understand pathways, because many of the mechanisms you might think for why depression treatment would affect willingness to pay also lead you to a greater use. So the kind of preference pathways, the marginal utility of the product, right? If my marginal utility goes up, I should both use it more and demand it more. And so that we're not seeing that, we think is most consistent with the cost of action pathway, the final one, which is if it's challenging to make a decision about a new product and depression exacerbates that cost, then I'm going to have a hard time buying it, or I'm going to be willing to pay less for it. But if you gave it to me, then I would use it. And so that, I think, is what's most consistent with these results. And then just to close, I think there are a lot of policy implications here from this. So first, if you're kind of asking, should we have free distribution or cost sharing, in contexts where there's endemic depression, depression may make it so that people are not willing to cost share or pay some portion of the cost. And that would favor free distribution in those settings. Now, in general, not everybody's depressed, and so this mechanism doesn't apply to everybody, but we have some settings where you would really think a lot of people are depressed, so refugees, people in conflict zones, or, I would argue, people who are just in general poor, you're going to see very pervasive depression there. And then to kind of move beyond that, if you had a fixed budget for providing some health product, that, it's maybe not just a matter of do I charge you for this or do I give it to you for free, but you could spend the same amount of money to create point of use distribution, at least for some goods. So imagine for hand sanitizer, instead of charging people 50%, I use that money to put stations outside latrines where people can get hand sanitizer for free. So that would, under these kind of the mechanisms we have in mind here, overcome the cost of action that seems to be preventing people from adopting and would allow a broader set of people to use the product. And so I think thinking through these psychological mechanisms leads you kind of to a broader paradigm about how we can provide these health products and what is the optimal way to do that. And I don't claim to say that this is the answer, but I think it raises some questions that we can think about. So there. Thank you very much.
Thank you for that. You win the prize. 2 papers in a 15-minute slot. That's definitely prize-worthy. So I have a question about the mechanisms on the second one. One that I didn't see you list but seems plausible, or maybe it's a combination of what you did list, is, and I guess it's under preferences, but it's like, endogenous time horizons or something, right? Because the one difference between cookies and hand sanitizers are preventative, and so they they invoke something about planning or preparing or some caution or some precautionary behavior. So anything you can say from the evidence about endogenous time horizons, if this is about time preferences or truncated time horizons?
So I think that's a great question, and I think that this is a little bit complicated, and I don't know if I have a very good answer for that. I mean, I think that one explanation for what we see with no effect on use, but yes, an effect on demand, you have to worry about the possibility that people may kind of treasure the good. So it could be that because I value this so much, I want to keep it for that special time when I need it, and then that would kind of confound what we're finding. And I'm aware that this is an issue, and I haven't yet kind of thought about it. And I guess more generally, your question is, do we have kind of I think you make a good point, but I guess I wish we had better measures of that so that I could say more about it. But I think it's something we take under consideration and try to address.
I think we're going to try to keep moving. Yeah, we got one in the back. Okay, great. And then we'll move on after that.
Hi, thanks. It was really interesting to see the willingness to pay for a health good, which does not work the way that my studies worked. So I'm glad to see it may have worked for you, but I'm wondering how you assess the social desirability bias of someone saying, like, yes, of course I'll buy your soap, because they think that you think they want them to buy the soap. I did a study on ventilation, which was an unknown product. It was like a skylight, essentially. And we had most people refuse to participate in the auction because they didn't understand the value of the intervention, the new thing, and because they were unwilling to bid zero. Right? They didn't want to give the impression that we're poor or that we don't want the thing that you're asking us to do, so they just dropped out. And so we conducted follow-up qualitative evaluations to say, oh, you said you'd participate, you said that you weren't going to modify your house, and that's why we enrolled you in this study, and then you later dropped out of the auction because you said you were going to renovate your house. What's going on? And then after 20 minutes, they were like, oh, I just didn't want to spend any money. And so I was also wondering if you followed up on the willingness to pay with like the actual payment for the hand soap, and did you find different results?
Yes. So thank you for that. That's a great point. I think 86% of the people who were supposed to buy the product did buy the product. The social desirability bias, I think, is something to bear in mind with these situations, and I would just kind of lean on the treatment versus control. I'm comparing the people who got this pharmacotherapy to the people who didn't, and they all were kind of received the same. They went through the same experience of eliciting willingness to pay. So it would have to be something about how that differentially affects people who were treated for depression, I guess. But it's certainly something to think about.